I'd like to welcome everyone to the Antimicrobial Stewardship Project webinar series. We're so pleased to have you with us today. The webinar today is the first of a three-part series focused on enhancing antimicrobial stewardship outcomes with diagnostics. As you can see on our first slide, we've got three groups that have helped organize that we're so thankful for their collaboration. The Center for Infectious Disease Research and Policy, Society for Infectious Diseases Pharmacists, and ProCE in facilitating all the CE we have to offer you today. We have two infectious diseases experts today that have graciously made time for us and all the preparation that went into this during a very busy time of the year. Dr. Ferric Fang and Dr. Katherine Perez. Just a brief background on them. Dr. Ferric Fang is professor of laboratory medicine, microbiology, and global health at the University of Washington School of Medicine in Seattle. He obtained his undergraduate and medical education at Harvard University and his postdoctoral clinical and research training at the University of California, San Diego. He has 35 years of experience as a clinician, educator, and researcher. Focused on bacterial genetics and pathogenesis. He's published 240 peer-reviewed articles and currently serves as a director of clinical microbiology at Harborview Medical Center, and is also the deputy editor of the IDSA Journal of Clinical Infectious Diseases. So he's bringing to us today the perspective of the clinical microbiology lab and how their role in diagnostic stewardship. He's former editor-in-chief of the ASM Journal Infection and Immunity and fellow of the American Association for the Advancement of Science, the Association of American Physicians, and the American Academy of Microbiology, and the American Society of Clinical Investigation. Katherine Perez is our second speaker today. So pleased that she could join us. She's an infectious diseases clinical specialist at Houston Methodist in Houston, Texas, assistant professor of health sciences at the Institute of Academic Medicine, and assistant clinical member of Houston Methodist Research Institute. In her current position, she's responsible for developing, coordinating, and co-directing antimicrobial stewardship efforts across the Houston Methodist healthcare system. She's been published numerous times for you. Many of you I know are familiar with her research, and she'll be presenting that today, specifically focused on the use of rapid diagnostics and antimicrobial stewardship. So I'm happy to welcome them, and you'll be hearing from them very shortly. I need to present a few slides to you before we begin. The learning objectives for this webinar, describing diagnostic stewardship and understand how to use diagnostic assays, including rapid diagnostics. Our speakers will help to explain how diagnostic stewardship enhances antimicrobial stewardship programs, and further, they will characterize how clinicians, antimicrobial stewards, collaborate with the clinical microbiology laboratory successfully to achieve desired outcomes. We have a lot of CE that we're offering with this webinar. For pharmacists, ACPE, you will receive 1.25 credit hours for this planned webinar activity. So it's a webinar and there's a Q&A session at the end. So please stay on for that. Submit your comments to us, and then you'll receive a code at the end to receive your CE. We also have physician, ACCME, CE today, and for nurses, we have continuing education as well, and for the laboratory professionals, the PACE program. Finally, in addition to this, we are offering BCIDP recertification credit. And we've got several members of that team that have helped us develop those questions for you. So please proceed to successfully complete your post-test. You will only have one attempt. No partial credit will be given, and accreditation begins today for this activity, and it's available for 1 year from this date. So please, please take advantage of this. Our audience is all of you, physicians, pharmacists, nurses, and clinical laboratory professionals. And we would very much like to thank bioMérieux for the educational grant to bring you not only this webinar, but 2 more that will be happening as part of this 3-part series, the second one in February and the third in April. Disclosures for all of those of us involved, from the planning to the speakers. We have no relevant conflicts of interest to report at this time. Finally, how to achieve your CE. Go to proce.com after this live webinar. You'll have questions there, post-test evaluation questions. The deadline to receive credits for the live webinar is January 15th of next year, and attendance code is provided at the end of the webinar. So with that, I'm ready to turn it over to Dr. Fang, and he'll begin his webinar. Welcome, Dr. Fang.
Thank you so much, Marnie. It's a great pleasure to be with you all today. I'm really honored to have the opportunity to speak to you about this important topic of diagnostic stewardship. And it's a particular pleasure to be presenting along with Dr. Katherine Perez, who's really done some seminal work in this area. As shown by Louis Pasteur and Sir William Osler here, diagnostic stewardship links the laboratory and the bedside to allow us to optimize the treatment of infectious diseases. So first, a few definitions. What is diagnostic stewardship? The World Health Organization has defined diagnostic stewardship as coordinated guidance and interventions to improve the appropriate use of microbiological diagnostics to guide therapeutic decisions. Diagnostic stewardship should promote appropriate and timely diagnostic testing, including specimen collection, pathogen identification, and accurate, timely reporting of results to guide patient treatment. In a commentary that we wrote a couple of years ago, Robin Patel and I further specified that diagnostic stewardship is more than simply the cost-effective use of laboratory tests. Some people have encouraged this more restricted definition, but really diagnostic stewardship is more than that. It certainly encompasses cost-effective use of laboratory tests, but we regard it as the appropriate use of laboratory testing to guide patient management in order to optimize clinical outcomes and limit the spread of antimicrobial resistance. The emphasis is really on outcomes, and this becomes important as one tries to determine whether or not stewardship interventions are effective. And this is something that Dr. Perez, I believe, is going to discuss with you in depth. Many diagnostic stewardship interventions rely on rapid diagnostic tests, or RDT. And here are some of the platforms that we're going to be mentioning today. Everyone is certainly familiar with PCR, the polymerase chain reaction, which is used to amplify specific nucleic acid target sequences. Microarrays have specific probes that recognize labeled target nucleic acids. MALDI-TOF MS uses mass spectrometry to detect the spectra of ionized proteins that are generated from whole microorganisms. And PNA FISH uses peptide nucleic acid probes to recognize target organisms on smears by fluorescence microscopy. One very nice analysis of the potential usefulness of rapid diagnostic testing in patients who have bacteremia came from the Mayo Clinic and was published a few years ago by Ritu Banerjee, Robin Patel, and their colleagues. It's fairly uncommon to see true randomized clinical trials in clinical microbiology, but these investigators performed a true RCT to compare conventional blood culture and identification methods with blood culture followed by rapid PCR, or blood culture with rapid PCR coupled with antimicrobial stewardship guidance. And they did this in 743 patients who had positive blood cultures. An important impact of rapid PCR was that it reduced the treatment of contaminants by identifying rapidly skin organisms like coagulase negative staphylococci from single blood culture sets. And I think we would all agree that in most cases, such isolates do not require treatment, but in the past, it was common for empirical vancomycin to be administered until the organism could be identified and Staph aureus could be ruled out. But PCR allowed this to be recognized very quickly and so reduced unnecessary treatment of contaminants. It also shortened the time to antibiotic escalation when a target organism was found that was not being covered by the empiric regimen. However, it's important to note in the little triangles here with D showing de-escalation, that cutting back on existing empirical therapy only occurred when rapid diagnostic testing was coupled with antimicrobial stewardship. This shows that antimicrobial stewardship programs have a crucial role in coupling the laboratory and the clinical service. Antibiotic decisions have become increasingly complex. We have multi-drug resistant organisms, new antimicrobial agents, and we have pharmacokinetic, pharmacodynamic considerations in optimizing therapy. And for some clinicians, this can be a little bit overwhelming, and many clinicians are more comfortable expanding the antibiotic coverage that they've started than cutting back, especially when you have a very sick patient. However, unnecessary antibiotics can increase the risk of adverse events, things like Clostridium difficile infections, drug interactions, and disruption of the microbiota. So it actually is very important to de-escalate as well as escalate. And this is a goal of stewardship that helps the patient and also reduce the costs of medical care and the selection pressure for antibiotic resistance. And having a stewardship program in place, specialists who really understand the implications of the diagnostic test results can give clinicians the confidence to de-escalate therapy as well as escalate therapy on the basis of the rapid test results. In terms of having measurable clinical outcomes, the investigators in the study actually were not able to show a difference in mortality of the patients, hospital length of stay, or costs. But there were some favorable trends, and it's possible and perhaps likely that the lack of impact demonstrated was mostly due to the sample size and an underpowered study, because others have gone on to show beneficial impacts of stewardship and rapid testing. Other studies, such as this one from Rutgers in New Jersey, have confirmed that stewardship augments the clinical impact of rapid testing and improves the treatment of both contaminants by avoiding unnecessary therapy and true bacteremia by ensuring appropriate coverage. Importantly, and this has a lot of implications for the workforce, as shown in this study from the University of Utah, it makes a difference whether you provide real-time stewardship support, having the pager on 24 hours a day, 7 days a week, rather than Monday through Friday during business hours. This more rapid real-time stewardship is likely to result in better outcomes for critically ill patients, where every hour can make a difference. Persuading hospital administrators to adequately provide resources for antimicrobial stewardship programs requires data. If any of you have engaged in this discussion, and this analysis shows that a variety of rapid methods coupled with stewardship programs have been determined to be highly cost-effective in terms of incremental cost-effectiveness ratios, the ICER, expressed here as dollars per quality adjusted life year gained, and interventions that cost less than $50,000 to $60,000 per quality gained are generally regarded as being efficient and cost-effective. And so a variety of approaches may be used and have been shown to be highly cost-effective. And this is really important to point out to hospital administrators, because the cost that they put into the laboratory and the stewardship program will pay them back in terms of costs of antibiotic therapy and numbers of days in the hospital. A meta-analysis of 31 different studies concluded that rapid diagnostic testing is more effective when it's combined with a stewardship program in patients who have bloodstream infections. And this is a forest plot, which you're probably used to seeing from meta-analyses, that shows that the rapid diagnostic tests were associated with a decrease in mortality risk, but this really became significant only when combined with an antimicrobial stewardship program, but not without one. And interestingly, the same analysis found that the greatest mortality impact was seen in patients who have gram-negative bacterial infections. But this really makes sense when you think about the fact that a lot of our most challenging multi-drug resistance problems are showing up in gram-negative infections, and gram-negative bacteremia is also associated with a particularly high mortality and rapid mortality. So rapid diagnostic tests don't have much of an impact unless you can translate these rapid results into rapid clinical decisions that optimize therapy. And this is really the critical role of having an antimicrobial stewardship team that's well integrated, both with the primary clinical services and with the laboratory. The benefits of rapid diagnostics are not limited to bloodstream infections. Rapid diagnostic panels that include most of the common causes of community-acquired pneumonia are now available or emerging. And early indications suggest that antibiotics might be safely deferred in patients who don't have a detectable bacterial pathogen, perhaps have a viral pathogen detected, and have a normal biomarker of infection, most commonly in the form of procalcitonin. This approach would have averted about 20% of antibiotic use in patients who were hospitalized for CAP in the Providence healthcare system in this study from David Gilbert in Portland, Oregon. A recent study from the outstanding group of Emilio Buza in Madrid, Spain, used a rapid diagnostic test in patients who had skin and skin structure infections to guide treatment decisions. They were able to show that using a rapid diagnostic reduced days of treatment, healthcare costs, length of stay, incidence of C. difficile infection, and attributable mortality, which sounds like a lot, but it really all poured downstream because of the timely targeting of anti-staphylococcal antibiotics. If you can limit those antibiotics to the people who really need it and make sure the people who have staph infections get anti-staphylococcal therapy, and you can recognize methicillin resistance versus susceptibility, you can make a big difference in downstream clinical outcomes. At my own institution, the University of Washington, we assessed the impact of a rapid multiplex PCR panel for GI infections, patients who presented with acute gastroenteritis and diarrhea. And instead of having to wait 60 to 75 hours to get a stool culture result, clinicians got results on the average 2 hours after they had submitted the specimen. This did not, interestingly, reduce overall antibiotic use because we identified so many more enteropathogens than conventional methods. And so this actually elicited antibiotic use. So total antibiotic use was very similar, but the big improvement was seen in appropriate antibiotic use. So instead of relying on guesswork before the intervention of the rapid diagnostic, a lot of people with viral gastroenteritis were getting antibiotics, and a lot of people with bacterial gastroenteritis were not. Instead, patients were getting treated more promptly, and they were getting treated in a targeted way for what they actually had. And this is very likely to result in better outcomes, although they weren't measured in the study. Patients got more treated more quickly, and they got treated more appropriately as a result of the rapid diagnostics. Diagnostics, as you know, play a very important role in the diagnosis of C. difficile infections, and this has been kind of a controversial area and something that's been very interesting to me. But as seen in this study, I think very clearly, whether you're looking at PCR, which is being measured on the left, or whether you're looking at toxin concentrations, which is being measured on the right, the diagnostic test cannot distinguish between whether patients are colonized, which are shown in the right side of each of these graphs, or have a clinical infection, which is shown on the left side. This is something which has been controversial because some people have suggested that toxin assays, as opposed to PCR assays, can distinguish whether people are colonized or infected. But this is in fact not true. And if you look at the data, you can see very clearly that some carriers who had no symptoms at all had high toxin levels that were measured in the stool, and some people who had CDI disease did not have detectable toxin and were detected by PCR. So we cannot rely on the laboratory to tell us who's colonized and who's infected. We have to actually look at how the patient is at the bedside. And the best way to appropriately utilize diagnostic testing for C. difficile is to make sure that only the right people are being tested. And diagnostic stewardship then comes to the rescue by limiting testing to people who meet clinical criteria for CDI rather than colonization. Without such criteria, it's impossible to avoid inappropriate testing and unnecessary treatment of people who are colonized, and those people will not benefit from antibiotics. So this is really a great example of how important it is for stewardship, but here stewardship is deciding who should be tested rather than translating the results of the test to the bedside. An analogous situation is encountered in catheter-associated urinary tract infections. It's really common, especially with older patients and catheterized patients, to have asymptomatic bacteriuria. Indiscriminate urine culturing leads to indiscriminate treatment. And this study that just came out from friends and colleagues of mine at the University of Southern California in clinical infectious diseases showed that a simple classical intervention with education, audit, and feedback dramatically reduced the number of urine cultures which had been being sent from patients who had catheters. A lot of these were automatic orders, and nurses were sending orders without clear clinical indications. And this was resulting in high institutional rates of catheter-associated UTIs for which institutions are penalized, and also lots of unnecessary antibiotic treatment, which are not going to benefit those patients. So by simply introducing this intervention, they reduced the number of orders for urine cultures in patients who didn't need them, and the catheter-associated UTI rates for the institution went down to low levels and stayed down, and this was helpful for everyone. And they also measured the possibility that they were having an adverse effect on failing to detect important urinary tract infections, and they saw no increase in mortality or mortality associated with urinary tract infections. So this is an approach that could easily be mimicked at institutions all over the world. Rapid diagnostics are not limited to tests that detect microbes. Earlier, I had mentioned in community-acquired pneumonia, or CAP, that procalcitonin is increasingly used, which is a biomarker to try to differentiate bacterial infection from viral infection or non-bacterial infections. But it's also being used in the ICU setting to identify patients in whom antibiotics may be safely discontinued. And accumulating evidence suggests that this approach can reduce antibiotic exposure. A variety of biomarkers are currently under investigation in addition to procalcitonin to be able to distinguish bacterial and viral infections. Ideally, something that could be done at point of care, say in a doctor's office. And this is one platform that's being developed that uses the biomarkers TRAIL, IP10, and CRP, which collectively have better accuracy than just one alone. And in a study here published in Lancet Infectious Disease in young children who were presenting with a fever and possible respiratory infection, they found that the negative predictive value for these three biomarkers was nearly 98%. And this suggests that this could really help pediatricians and family doctors in the clinic avoid unnecessary antibiotic use. The CDC estimates that approximately half of antibiotic prescriptions given for acute respiratory conditions in the outpatient setting are in fact unnecessary. So this is a great opportunity for diagnostic stewardship. And finally, rapid diagnostics can help to narrow the spectrum of empiric antimicrobial therapy. The community-acquired pneumonia guidelines make recommendations based on whether or not you have a high prevalence of MRSA, and then you have to include a drug like vancomycin or linezolid. However, fear of MRSA greatly exceeds the actual incidence of MRSA, and this has been shown in multiple settings. And so there's a lot more empirical vancomycin or linezolid being given than actually benefits patients. And a number of studies have now indicated that rapid diagnostic tests, such as using a molecular test to determine whether MRSA is present in a nasal specimen, have a high negative predictive value for excluding MRSA in patients with pneumonia. And this can help to reduce unnecessary use of anti-MRSA agents. So the basic principle of antimicrobial stewardship is to use the right drug at the right time, at the right dose, and the right duration. This is extended by diagnostic stewardship. Now we say to use the right test in the right patient, and this can help us to use the right drug at the right time, at the right dose, and for the right duration. Diagnostic stewardship links the microlaboratory with the patient's bedside, and it guides both the appropriate utilization and the appropriate interpretation of test results, and translates this into better clinical outcomes. But to realize this vision requires teamwork, seamless communication, and between the laboratory, the stewardship program, and the clinicians. And so now I'm very pleased to hand things over to Dr. Perez.
As Dr. Perez is coming online, I just wanted to let all of our listeners today know that these slides will be made available at the end of our presentation and will be posted to our CIDRAP website. And thank you for your questions that are already coming in. So that you're aware, we will have time at the end to address them. So with that, Dr. Perez, go ahead with your presentation. Thank you.
Okay. Thank you, Marnie, for the introduction and the invitation to speak with you today about diagnostic and antimicrobial stewardship. It really is a privilege to get to discuss this topic alongside Dr. Fang, who continues to do incredible work in this arena. This topic is certainly near and dear to my heart, as I've been working very closely with the microbiology lab for almost 10 years here at Houston Methodist Hospital as an ID pharmacist. Also, so thank you, Dr. Fang, for the great segue. I promise we didn't plan this. We ended up having that, he ended up having that last slide, and then I ended up having this on the very first. So hopefully I can pick up where he's left off. So diagnostic stewardship and antimicrobial stewardship are both two components that are absolutely necessary to ensure that all of these new and rapid technologies conserve additional healthcare resources as opposed to consume, and optimally affect what actions we take with our patients at the bedside. As Dr. Fang articulated so well, no benefit in any of these rapid results or laboratory efforts are realized if no one is around to actually act on them. In the same way that an antimicrobial stewardship program has a mantra for right drug, right time, right dose, the diagnostic side promotes a very similar mantra with right test, right patient, right time. And together, the two create an environment that's really ripe with opportunity to leverage one another to drive appropriate treatment selections for our patients. And frankly, that is no matter what kind of technology you have, high or low tech solutions. I'll describe some collaborative approaches that we can take to optimize implementation of new and existing diagnostics. And by the end of this, I hope that you'll be thinking of ways to tell your own story. So this slide captures many of the existing clinical laboratory functions that have been benefiting the antimicrobial stewardship program for years and years, and far longer than antimicrobial stewardship programs have been a thing per CMS or the Joint Commission. The antimicrobial stewardship program, in some form or fashion, has been working with the laboratory to strategically report antibiotic susceptibilities with things like selective reporting, cascade reporting for supplemental agents, and multi-drug resistant organisms, helping to construct interpretive comments, which always turns out to be a lot more difficult than you think it's going to be. So, those are the comments that appear on the results, and then also serving as a venue for a lot of these discussions to be had so that there's input from multidisciplinary stakeholders and so that there's an awareness and a mechanism for feedback. Here's just one example, looking at the effect of selective reporting, for instance. This group in Toronto conducted an interrupted time series over several years, 2008 through 2015, and in 2011, they implemented a policy to suppress ciprofloxacin susceptibilities for all of their gram-negatives as long as the organisms were susceptible to other antibiotic classes. And if you look at the chart on the left side, left bottom of trending the antimicrobial use over time, talk about a money shot. You can see a significant and immediate decline in the ciprofloxacin use following that very simple intervention. And the best part of this is that it was sustained throughout the post-intervention period. In an effort to make sure that all of us could sleep at night, the investigators did go ahead and look at where the antimicrobial use shifted and found that there was an increase in use of amoxicillin clavulanate, which, again, I think everyone can agree that is a much healthier alternative to a fluoroquinolone. So great news there. And they also found a significant increase in their quinolone susceptibility patterns, particularly with E. coli and with Pseudomonas, which, again, you would expect, but it's so nice when you can see it play out in a study this way. Here's another study where the authors made a very small change in the way that they reported out their respiratory culture results. They leveraged the language in their microbiology interpretive comments that you see here highlighted on this slide. On the left side, you see the reporting used to only say commensal respiratory flora only, compared to the right side where they added in no Staph aureus / MRSA or Pseudomonas aeruginosa. With this one very small change, they were able to significantly steer prescribers away from continuing empiric or just having any anti-MRSA or anti-pseudomonal antibiotics. So this persisted even after the authors actually controlled for a number of other variables. The comment in and of itself was associated with a 5.5-fold increased odds of de-escalation. So this is really, really great stuff. And again, these are only two examples among many out there that are showing these kinds of tangible benefits that we can apply today in our lab with our laboratory. So switching gears to the rapid diagnostics arena in the laboratory, this is an area that has truly exploded over the last decade, and there's been a dramatic shift in focus on the race against time. This is, certainly warranted as literature continues to demonstrate that bad things happen to patients when you delay critical results, particularly among patients with difficult to treat infections. So the role of rapid diagnostics has been highlighted as a key recommendation for antimicrobial stewardship programs by the IDSA and other professional organizations. And there are more and more data published to support this collaboration in a number of settings. These technologies vary greatly, but they are all largely focused on critical specimen types like blood, CSF, respiratory samples, and clinical syndromes that carry high morbidity and mortality, as well as those with infection control implications. Okay, so for anyone in the audience who is still not familiar with what we're referring to when we say rapid diagnostics, I do want to quickly orient you to a conventional timeline for a clinical specimen. In this case, a blood culture up top, compared with what you would expect with a rapid diagnostic, in this case, a multiplex PCR directly below. Again, this is an extreme generalization type of illustration, but I think you'll get the point. What you can see is that at time 0, that is really when your patient has their blood cultures drawn and sent to the laboratory. And while all of this is going on, your patient has more than likely been started on empiric antibiotics. And with traditional ID and antimicrobial susceptibility testing methods, you can see that it can take anywhere from 2 to 4 days before you have enough information to tailor your patient's antibiotic therapy, compared to when you use one of your rapid diagnostics du jour, again, in this case, PCR, you can typically get that ID and sometimes even some susceptibility information much, much sooner, right after you get that gram stain, and tailor antibiotics at that point. And so that information is actionable and can really affect the patient at the bedside. But does this actually happen? So does this benefit actually play out and translate into better outcomes for patient care? this was a question that we asked at our own institution following implementation of the MALDI-TOF for identification of gram-negative bacteria directly from positive blood cultures. So we actually implemented this right off the bat with a real-time antimicrobial stewardship notification and follow-up. So you can see here, this timeline graphic is similar to the one I previously described. Up top, you have the pre-intervention timeline where everything was conventional, and then below you have the intervention timeline with the MALDI-TOF. And you can see that there was a significant decrease in time to identification and susceptibility. And what was really unexpected, and maybe not so much in hindsight, but at the time, we were really surprised at how long it took our clinicians to act on data, even once it was made available. So even after you had the susceptibility results, it was still taking clinicians another day to actually adjust or tailor their antibiotic therapy. And down at the bottom, you can see what was actually most humbling, which was among patients who were on ineffective treatment or no treatment at all. We did see that at the 24-hour mark, the majority of these patients had been started on some effective treatment, and by 48 hours, they had all been started on appropriate treatment once we implemented this rapid diagnostic and stewardship initiative. So this is definitely a recurring theme. There have been several studies, including a few that I've had the privilege of working on, that have demonstrated success with MALDI-TOF, specifically with an antimicrobial stewardship intervention. These are, again, just a few, definitely not all inclusive, but I've summarized some of their outcomes here. I do want to draw your attention to the identification row, and with the exception of the last column on the right in the study by Beganovic and colleagues who used MALDI-TOF during both study timeframes and actually looked at the effect of the stewardship intervention itself, you can see across the board that there is considerable reduction in time to identification, which again is something that you would expect. There is some variability due to the techniques used, either MALDI-TOF from a culture plate or directly from a positive blood culture. But again, you know, at the end of the day, the takeaway is the same. You have clear benefits with reduction in time to effective and optimal antibiotics. So we know that these process outcomes change when you implement these diagnostic methods and follow them with an antimicrobial stewardship initiative. We know this, it's a recurrent theme in the literature, but when you look at the clinical outcomes, the ICU length of stay, the hospital length of stay, costs, mortality, these have been way more of a mixed bag. And this is also a consistent theme in the literature that I'll circle back to a little later. So as we worked through our process at Houston Methodist, I personally became more and more convinced that much of the benefit that drove the significant clinical and economic outcomes lived among patients with antibiotic-resistant infections. So once we had enough data in that patient population specifically, we went ahead and analyzed it in a similar fashion. And we found that the stewardship team actually played a very significant role before the organism's susceptibilities were even known. So just by having the identification and looking at the patient clinical picture, so reviewing the patient's chart, looking at their history, their antibiotic exposures, and other risk factors, the stewardship pharmacists were actually able to make significant improvements in someone's antibiotic regimen right off the bat before we even had susceptibilities. And in opposition to the antibiotic police dogma, the stewardship team was actually responsible for escalating therapy to things like carbapenems about half the time. So showing this kind of data to our clinicians has really gone a long way. And frankly, it's paved the way to acceptance of some of our other crazy ideas. So here's another table looking at different outcomes that antimicrobial stewardship programs have published on with a number of different rapid diagnostics. You will see the reduction in turnaround time across the board as expected, but the clinical impact, again, is a mixed bag. Some have shown reductions in cost or length of stay, while others have only demonstrated an improved time to optimal therapy. And I think a lot of this has to do with what the baseline practice is like at your institution and how your empiric therapy lines up against your resistance rates. So again, before anybody runs out and asks their C-suite to cut a check, please, I cannot caution the audience enough to be careful to not oversell expectations, because it's so important to recognize what the patient population was, what the resistance rates were like, and if that's comparable to what's happening in your institution, and then partner that with what laboratory and antimicrobial stewardship resources were available to actually operationalize some of these interventions. So this is a study that Dr. Fang referenced in his talk as well. And it's out of the Mayo Clinic, and it's probably the strongest data set out there demonstrating how important that active antimicrobial stewardship intervention piece is to actually realizing the turnaround time benefit. This was a prospective randomized clinical trial. Yes, that's right. As Dr. Fang mentioned, it's extremely rare to have this kind of data in this arena. So this was a randomized control trial comparing antimicrobial utilization with outcomes among patients with positive blood cultures who received standard culture identification with MALDI-TOF and antimicrobial susceptibility testing alone, or with a rapid multiplex PCR, or with the PCR and a real-time review by the stewardship team. So just looking at this information quickly, a couple of things are pretty obvious. We definitely find that dramatic benefit in time to identification, as you would expect. And then you also see that we certainly don't have a problem escalating therapy when it's needed. That's not an issue here. But then you have to go all the way past a full 36 hours to see a de-escalation. So even in the middle group where you have rapid results available, without the stewardship team, you do not see as much benefit in the time to de-escalation. Again, a recurring theme throughout the literature. So despite the improvements in the antibiotic use, though, this study found no difference in length of stay, mortality, or cost. They did note that de-escalation happens sooner among patients with the gram-positive infections, where the MEC-A and the VAN-A-B markers can really help drive therapy, when compared to no difference really in the de-escalation times for the gram-negative agents like meropenem or zosyn. And the truth is that nowadays, that really isn't that hard to believe. De-escalation in a patient with a Klebsiella bloodstream infection, just because you know they don't have a KPC, is difficult, depending on where you practice. So chances are you're not starting off with ceftaz-avibactam or Vabomere. So you typically end up leaving them on whatever they're on until you have those susceptibility results in front of you. And so again, you know, with gram-positives, you end up doing pretty well with these type of interventions, and there's a lot of publications that in a number of settings that have demonstrated this. But with the gram-negatives, it's much harder because of the emerging and the complex resistance mechanisms out there. So I want to briefly discuss this publication out of the Hopkins group that illustrates the anticipated timeline for a real-time whole genome sequencing. Typically, this stuff is far too dense for me to follow, but I really liked how this paper put very complicated science in terms that anyone could understand. So this hypothetical timeline compared what the normal treatment timeline for a patient with a carbapenem-resistant Klebsiella looks like to what it could look like if we were able to build the bioinformatics support for real-time sequencing and detection of drug-resistant genes. And you can see where the red arrow here actually indicates on the timeline results in a 24 to 48 hour reduction in time to effective therapy for this multi-drug resistant Klebsiella. So while we are certainly not here yet, once something like this is widely available, we're going to have to ask the same questions that we're asking today. We'll have to make the same considerations to the workflow and the deployment of our resources so that they are actionable and translate to improved patient care. All right, so that's a bunch of great data, but where do I actually start? So in my role now as the stewardship pharmacist for an 8-hospital system, you quickly learn that one size does not fit all. And just because something sounds like a great idea in one hospital certainly doesn't mean that it will pan out across the enterprise. So the game plan that I provide our ID pharmacists with is simple. Pick something, anything that is meaningful to you, to your clinical laboratory, to your institution, to your providers. It could be procalcitonin, the MRSA nasal swab, asymptomatic bacteria, CRE, and really try to find out what the burden is at your institution. So grab someone in finance, someone who can actually help you put it on paper, describe the problem, and put a rough estimate of what the burden looks like. And then once you've got that together, you can work closely with your clinical laboratory director to think of ways to refine that process and intervene. And even when you think you've got it ironed out, you probably don't. So that close collaboration is really extra important to maintain. Think about starting with a pilot on a specific hospital unit or with a hospital service line, and then just give yourself 3 to 6 months. In general, that's about enough time you need for everyone involved to identify any major barriers, red flags, and really to sort. Working out a cohesive plan with your providers is also extremely critical. These are elements that I always come back to at the end of the day when I'm trying to put together a tip sheet or a provider newsletter, is have we addressed the new diagnostic, the why, the when, really conveyed our true intention or target population, and then also provided everyone with the operational items that inevitably do come up, like cost, turnaround time, and then make sure that we are describing the role that we will play in supporting these efforts. The planning and implementing steps are really only half the battle. This is where I certainly see a lot of programs with good intentions fall short, because it is just as important to determine how a diagnostic and stewardship program or antimicrobial stewardship program will deliver feedback and data to providers as it operationalizes a lot of these new initiatives. So letting people know how your efforts have affected their patients at the bedside is the stuff that really, really, really counts. So make it a thing. Showcase the findings in front of as many stakeholders as possible until it becomes the norm. Always be critical of the information you collect and stress test it so that you can always maintain quality improvement in your efforts. And, that way you can really demonstrate whether having a pager 24/7 is just as good as having a pager, 10 hours a day or something like that, in order to really maintain the best possible outcomes for your patients. And I will leave it at that, and I'm happy to take any questions from the audience.
Thank you, Dr. Perez, and I'll invite Dr. Fang back. So we're entering into our question and answer and comment section of our presentation today. And thank you for those of you that have submitted already. I want to take advantage of the fact that we've got Dr. Fang, as I mentioned, director of the clinical microbiology lab at Harborview Medical Center. And then we've got Dr. Perez leading the efforts across her healthcare system in Houston Medicine for antimicrobial stewardship. So diagnostic stewardship, as mentioned, Dr. Fang, is the right test, right patient. And I'm wondering how, when the two entities for diagnostic stewardship, it's really the antimicrobial steward coming together with the clinical microbiology lab. And I'm wondering from your two perspectives, how do you best start to look at this from the clinical micro lab, the right test for the right patient? And really, how does this happen in real time? So I'm curious from your perspective, Dr. Fang, implementing it from the microbiology lab, getting the right test for the right patient, and maybe, I don't know what kind of example, maybe the urinary tract example, the catheter-associated urinary tract example might be one that you presented some data on.
Well, I think the key is to have a true team collaborative approach and real physical face-to-face interactions with each other. We don't make these decisions in a vacuum. So all of our decisions about new diagnostics, since the whole goal that we all share is to improve patient outcomes, we recognize that if we roll out something and it's not properly understood and implemented and stewardship isn't part of it, infection control and our ID clinicians and our primary services are part of it, or our ED, then it's going to fail. And so all of these things are done with lots of face-to-face discussions and consultation and things going back and forth. And we get also suggestions and requests from stewardship or from infection control or from our specialty services that we also take under consideration. So it's not a one-way street where we initiate what to test. But we all feel that we work as a seamless group of colleagues with mutual respect and appreciation for what each component brings to the table, and that we're all working together for a common goal. And we've become good friends as well as colleagues. And I think having this kind of relationship is really important. We still do in-person plate rounds in our laboratory with our consult team and with our pharmacists and stewardship program, as well as the pharmacy trainees. So they come from all the way up as students, recognizing that we're all working together as a seamless coordinated team, and that their role is absolutely essential. I think this is a key to having a successful program, is everybody bringing their respective expertise to the table and really listening to each other. And by the time we roll something out, it's completely coordinated with all the services. We know what's going to happen. We've prepared a lot of documentation and informed people beforehand. And I think this has worked out really well for us.
Thank you. Dr. Perez, do you have, from your perspective, an insight? So the clinical microbiology lab saying very much a team effort, creating the plan, documentation, and feedback. How have you approached it from the antimicrobial stewardship programming?
So, as Dr. Fang mentioned, I mean, we have very, very, very close collaboration. You know, it was a lot of the MALDI-TOF work that we did initially was right place, right time. I was rotating through the microbiology lab as this instrument was getting validated, and was learning about the laboratory validation process, and immediately, you know, I was just taken aback by the fact that we were going to have these results so quickly, and all I could think of was, oh my gosh, this could really help our patients, you know, at the bedside, or that, you know, I've been seeing on rounds and so on and so forth. And so what if I took that little bit of information back to our providers in real time and made sure that, you know, we were teeing up all of their antibiotics right then and there. And, you know, from the microbiology laboratory side of things, I mean, they were more than happy to have someone carry out that initiative. And together we would, actually meet once or twice a week, face to face, through the entire pilot period of it. And we were going back and forth. And, at the very beginning, I was actually having the lab call me with every single result. So I brought them lots of donuts, a lot of goodwill, and finally was able to find a way to automate that process through an electronic means. But all of that would not have been possible had we not had that relationship from the get-go, and that mutual respect for one another, that, I'm able to be this credible resource for our clinicians, and really carry a lot of and deliver a lot of that information in a way that's meaningful. And, we're not calling clinicians left and right just because they have a positive culture, but we're calling when it's actually applicable and necessary from a therapeutic standpoint.
Mm-hmm. So definitely the collaboration, and it's interesting how the movement towards this, unison or integration with the antimicrobial stewardship program and the laboratory into diagnostic stewardship that's happened over the last couple of years as the technology has increased and become more readily available. I have some specific questions that our participants want to ask. One of them, maybe Dr. Fang, you mentioned around C. difficile. People are wanting to know specifically around the types of tests and maybe the protocols you have in place around. You can molecularly identify C. difficile is there, but perhaps the toxin assay is negative. Do you have particular orders that you sequence the tests? Is it looking for toxin first and then molecular bacteria, intra-abdominal organisms second from the molecular aspect? They're curious about that.
So different laboratories pursue this in different ways. My feeling is that determining by a sensitive test, a nucleic acid amplification test, if toxigenic C. diff is present, combined with a careful clinical assessment, is necessary and sufficient for my assessment of CDI. We don't do toxin testing, and I feel that it's not necessary. If you do toxin testing, there is a correlation between toxin positivity and organism burden. And people who are toxin positive in a large study done by CDC had a higher risk of recurrence. And so there can be some utility. You could also get the same information from quantitation of your PCR result. So people who have very low cycle thresholds have high organism burdens, and they can predict more serious complications. And some studies, but not all, have even suggested you could have a cutoff that would predict whether or not the toxin would be positive. In other words, if you want that information, but you don't want to have to have the expense and the time of actually measuring toxin, you could use as a surrogate measure a cycle threshold. In my own practice, I don't find it to be necessary, because I've seen people with devastating C. difficile and negative toxin assays and have pancolitis and require a hemicolectomy with the organism grown and the PCR positive. And I've also seen people walking around completely asymptomatically with high organism burdens and toxin present, but they have immunity, and so they don't get disease.
Mm.
So that's my personal approach.
Yeah.
But I recognize that different laboratories do it
Yeah.
differently. I saw a question about GDH screening. Some laboratories use that, and it streamlines testing, but you do miss a few cases by GDH screening. So you have to decide where your trade-off is going to be. Yeah.
Thank you for that. That's so helpful. And I think that's exactly what the individual writing that question was seeking your perspective. Katherine, I want to ask you a question that pertains to de-escalation. With a rapid diagnostics for blood culture, well, I guess there's two questions here. The first one, if MRSA is not present in your blood culture, as you mentioned, you can de-escalate pretty rapidly from vancomycin, but what do you do when a gram-negative is identified, an Enterobacteriaceae or E. coli, and you're on pretty broad spectrums, antibiotics at that time for empiric therapy, maybe a carbapenem, but you know from your antibiogram that your susceptibilities in general for, let's say, a ceftriaxone or even a cefazolin are highly susceptible. How do you deal with that? You've got your rapid diagnostic information, and before some of maybe your susceptibility results come back for gram negatives.
So you start with stopping the vanc, because chances are that was part of their regimen to begin with. But you know, that's not an easy thing to address. It really takes looking at the full clinical picture, looking at the patient's previous antibiotic exposures, looking to see what organisms, if any, that they've grown in the past. Where is this patient coming from? Have they been in the hospital for a week, or did they just come in from the community? And what other risk factors do they have for multi-drug resistant organisms? And in some cases, it's pretty straightforward, and you can easily convince someone to come down to ceftriaxone or something like that. But in other cases, you know, we end up kind of just sitting tight, knowing that the susceptibilities will be out soon enough, and at that point make the call then. But again, when we looked at the patients with antibiotic resistant infections specifically, we found that there were many times that we would escalate treatment in those cases, because we did see that they had a history of an exposure to a carbapenem. And so chances are that whatever's growing now is going to, you know, warrant something a little more than whatever they're on, or they've had a history of an ESBL producer. And so, you know, until proven otherwise, that's how we're going to treat them. And so it really just depends on what your local antibiogram looks like and what your patient risk factors are.
All right, I'm going to pause before I carry on with the next question, just to let all our attendees see the code that I've also sent out via the chat box. The attendance code for you to claim your CE today is DR4DKH. So for those of you that may need to drop off, we provide the code there for you. And as I mentioned, the slides will be available at a later time. I have another question for Dr. Fang and both Dr. Perez. So you mentioned, Dr. Fang, in one of your slides that with the implementation of a rapid diagnostics, not necessarily our antibiotics in total decreased, antibiotic utilization. However, you have more accurate or targeted antimicrobial therapy versus empiric. So I'm wondering how you work together and how this is presented, because this can potentially get at what other metrics you're following here. Are we going to have decreased costs, and is it quality of care versus cost? So Dr. Fang, I'm wondering how you deal with that. I mean, obviously you're tracking that and it increases quality, but how do you deal with potentially the cost issue with quality?
So using a gastrointestinal pathogen panel was really driven by quality issues, but we had to demonstrate what the cost impact was going to be. And so when we looked at the cost issue, we weren't really trying to demonstrate a cost advantage, because we knew we were going to pick up many more pathogens than previously, and this was actually going to potentially increase costs. We knew that the reagent costs of doing the testing is higher because you can't beat the cost of a few plates. But we showed that in the laboratory that the intervention would be cost neutral, because the amount of time required to do a stool culture, it's very complicated. You have to have many serial steps where you're checking these plates and then subculturing and doing more testing on these isolates. The workflow ended up costing a lot in labor, and we were able to show that there was a revenue neutral aspect to the testing from the laboratory point of view. And then we were able to make the argument that by recognizing enteric infections, we were able to do targeted testing to get isolates for public health, and we were going to be more sensitive in identifying these pathogens, which was going to allow appropriate treatment, which would reduce shedding by these patients so they wouldn't be transmitting to others. So from a community point of view, arguably, it should beneficially impact incidence of illness. And for those patients, it should improve their clinical outcomes, because it's been shown for many of these pathogens like Shigella, Campylobacter, that treatment can shorten the duration of symptoms. And so since we were limiting testing to people who had been sick for at least 7 days or who had dysentery or severe illness, we could make a clinical argument that we help the patient, a public health argument that we identify more cases and allow them to stop outbreaks. And then the cost for the laboratory would not be greater than what they already were. And this allowed us to convince administrators that this was a worthwhile introduction.
Katherine, from your perspective, thank you for that example too, Dr. Fang.
Yeah, I mean, we do a lot of the same kind of cost analysis. I mean, we certainly don't have to do all of the labor and, you know, tech time and all of that stuff, but what we do have to consider is if we're looking for a specific syndrome, or if we're targeting patients who have an infection, we're not going to see a decrease in antibiotic use in those patients because they have an infection that, you know, that we are actually targeting treatment for. But is that treatment now more appropriate? Are they spending less time on multiple agents? Are they spending more time on narrow spectrum agents? Those are the types of metrics that we certainly look at and try to quantify. And then we look to see downstream, does that actually cause does that affect their length of stay? Does that affect their ability to get switched to an oral medication sooner? Those types of things, because, you know, antibiotics are not terribly expensive at this point. And so trying to make, to justify a return on investment just based on the cost of vancomycin is the losing battle. And if we can't continue to try to do that from a stewardship perspective, we have to try to look at the whole picture and look at the benefit that we're essentially having in the laboratory and on the inpatient transition of care to outpatient side as well. Look at the reduction in costs related to therapeutic drug monitoring, or actual, you know, time that it takes for our pharmacists to address those consults on a daily basis, and try to quantify those metrics.
Katherine, I'm going to ask you one follow-up. I've got 2 more questions here. One for you, Katherine, is you mentioned on your slide with the implementation of rapid diagnostics, then that data becomes available. And in the laboratory, they're pretty efficient at getting that data back to you pretty quickly as a clinician. And then it's trying to affect the time of which you have the information to the time of which you can make a change at the bedside. And you did a study and you noticed that, okay, we weren't doing it as quickly as we wanted to. We want to affect and get more synced, and you start to implement some practices. What are the things that you're doing or you're thinking about to try to go from information to affecting clinical practice at the bedside?
The best way to inform that kind of question, is to look at what's already happening. So that's the first thing I tell people, is just kind of sit down and actually map out what is happening today. So today you get these results, you have, you know, these susceptibility results in the chart. Look at, you know, 20 patients or so and just try to actually map out what is happening, because I guarantee you it will probably be humbling to look and see how long it actually does take clinicians to act on some of this information. And if you don't find that, then obviously that's not going to be a good opportunity for intervention. But that's going to be the best way to address those type of issues, is to look and see what the current practice is, and then look and see what the disease state is, and does it make a difference if I stop vancomycin at 2 in the morning, even though we have a standard administration time at 9 a.m. and I could easily wait till 7. All right, you implement some common sense into it as well. And, think about those types of, workflow logistics. Could you actually standardize the time for some of these antibiotics so that maybe, you don't have those effects, or you don't have to, try to enforce a 24/7 operation, and look at those types of issues. But really, it's looking at what's actually happening at your institution, and then essentially saying, I want to cut this much time, or I want to intervene right here to try to make that happen.
That's a good point. It's a workflow issue. Would you say within 24 hours is something you're targeting? Like it as far as making some sort of change or utilization of that diagnostic data? Are you trying to get below 24?
Yeah, I think that's reasonable. For a lot of these rapid diagnostics that are emerging, they're targeting disease states that carry a lot of morbidity and mortality. And typically that's due to delays in appropriate antibiotic therapy. And so I would say that those do tend to fall within the range of 24 to 48 hour type of differences and changes.
Mm-hmm. Dr. Fang, I'm going to give you the last question here. I want to go back to actually Katherine's slide about the future and whole genomic sequencing, and how, get some of your thoughts on that, and how you feel that data will be utilized in the future. I've heard some other individuals that lead clinical laboratories talk about this, and really feel that using that information and how we take all that data and put it down into some clinical decision making. So just your thoughts on that.
Well, whole genome sequencing as it applies to the kinds of issues we're talking about today is not going to be whole genome sequencing out of directly out of clinical samples where you have polymicrobial mixtures of organisms, and you're really going to have to sort that out before you can go. I don't think you're going to be able to take the enormous amount of metagenomic data that's coming out of, say, sequencing a sputum or a bronchoalveolar lavage, or even a urine, which turns out to be very microbially complex at a molecular level, even when you have a single dominant organism at a culture level. But if you have an organism and you do whole genome sequencing, one of the questions is how well can you predict from that sequence? Say the technology continues to advance and you can get the information in a few hours of the entire sequence, and you can assemble a tentative sequence. And let's overlook the trade-offs of the different platforms in terms of accuracy. For some organisms, it's remarkably easy to predict susceptibility. And the correlation between the genome and the phenotypic testing is really good. And organisms like Staph aureus, which we already understand very well, the molecular basis of most of the drug resistances, you can make a good prediction. For a lot of the enteric organisms, you can. But there are a few exceptions where even if you have all the time in the world to analyze the genome sequence, there's a lot of discordance. Pseudomonas is one example because of all of the efflux pumps and porin expression, and the fact that it's gene expression levels, not the presence or absence of a particular gene, that tells you the resistance. Enterobacter isolates can be very difficult to tell because there's so many different mutations in AMP-D that can lead to changes in AMP-C expression. And so there are going to be certain problematic organisms. And I think you already have an isolate by the time you get to that point. And if you can use something like a PCR-based or an array-based determination of which resistance determinants are there, I don't see whole genome sequencing as really giving you a lot more bang for the buck. It's a lot more work to do. Where I see in the immediate future whole genome sequencing potentially being really impactful is for tuberculosis, because it turns out to be very good at predicting sensi patterns, and it can do so much quicker than waiting for the laborious phenotypic testing. And with all the people who are getting MDR and XDR TB, I see this as really accelerating the use of targeted regimens that are really optimized for their particular isolate. So in the long run, it's exciting to have whole genome sequencing. It's clearly very useful for epidemiology. But I think the tools that we have in hand right now are pretty good for the job we're asking them to do. And so while I'm excited to see this area advance, I'm not preparing to bring it into the lab for this purpose anytime in the near future.
And thank you for your insights on the future. I appreciate that. I know that was putting you a little on the spot and you're following on to Dr. Perez's slide there, but it's very helpful for us to understand that from a clinical perspective. With that, we're out of time and I need to close. I wanted to thank Dr. Perez and Dr. Fang for your time. As we mentioned, this is a very busy time for you. Of course, we know we're still in the COVID pandemic. There's vaccines to be rolled out, so appreciate your expertise today and time. As I mentioned, this was a very collaborative effort. This is part one of a 3-part series, so stay tuned. And our speakers will be coming back to us on the part 3 component of this in April. So you'll have more time to engage with Dr. Perez and Dr. Fang at that time. The other acknowledgements are from Maya Peters and Carlos Cruz from the CIDRAP team, SIDP, our collaborative partner, were amazing, Bruce Jones, Kelly Ekavara, and Vasilios Athens, and ProCE, Richard Lewis, and Chris Meltzer. So thank you very much, and thank you, bioMérieux, for your support.